Hello, friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hello, friends. Welcome to part 3 of the trauma primary survey. I'm sorry that it has taken us so many episodes to get through the primary survey, but I do think there's tons of learning to be had in going over all of the main systems of the body very quickly. So we are going to finish off with disability and exposure today. This should be a relatively short episode. Hopefully, we can only hope. Last episode was supposed to be short, but it wasn't. So we are going to kick off by talking about disability. So when we are talking about disability, we are talking about the neurologic status of this patient. And sometimes you think of deformity in this as well. And so we've already spoken about making sure that if you see that a patient has like a leg in a conformation that is not normal and could be interrupting blood flow, could be compromising their nerves, like you should put that back where it belongs. But we sort of talked about that in as far as circulation is concerned. So we are going to focus on the neuro exam and namely the GCS exam in this episode. But when we do a neuro exam in the trauma bay during the primary survey, it is a very, very focused neurologic exam. And so some things that are always evaluated in the neuro exam include like the pupillary size. So you probably will hear the person who's standing at the head of the bed say something about how many millimeters the pupils are dilated. But typically the GCS exam is the thing that you're going to want to know the most about. GCS stands for Glasgow coma scale, and this is scored anywhere from 3 to 15. So 3 is the lowest score you can get, and I will repeat that. 3 is the lowest score you can get. You cannot get a 0, you cannot get a 1 or a 2. 3 is the lowest, and we will talk about why. And then 15 is the highest that you can get. Some things that you may hear on your trauma rotation or throughout the hospital as you interact with patients who are intubated is a GCS with a T at the end of it. So 3T is an intubated person who has a GCS of 3. And the reason this matters is part of the GCS exam is like a vocal response. And when you're intubated, it is difficult, if not impossible, for you to participate in a vocal response. Especially if you're sedated, those sorts of things can be difficult. So, talking about the components of the GCS exam, so there are 3, and the numbers add up to 15, but unfortunately they're not all 5. So, it is a response with your eyes, a response with your voice or vocal response, and then a motor response. Eyes can get a maximum score of 4, so I like to think of this as like 4 eyes. Vocal gets a maximum score of 5, and so the way me and my friends remember this is the Jackson 5. It's like a singing group, and so 5 is for vocal, and then 6 is the highest score you can get for your motor response, and you can think of this like a 6-cylinder if you feel like that's applicable to you. Feel free to tweak your memory tool, but it's 4 for eyes, 5 for vocal, 6 for motor. And then going specifically into how you score the patients, one thing that I think helped clear things up for me as I sort of progressed throughout medical school is that the GCS number that you give a person is their maximum response. And so let's say for motor, they score really high in their right arm, but they score pretty low in their left arm. You give them the highest score. So it doesn't matter if it's different throughout the body. It's the best that they can do with anything. So that's sort of how the GCS works. Okay, so starting with the eyes, remember that this can get 4 points. And so the highest that you can get is your eyes opening spontaneously, so being like awake and blinking and sort of interacting with your eyes. So that's a 4. 3 is opening your eyes to verbal command, and so you could get a point off if you are asleep. So you can get a point off if you're sleeping when they come in, if that's how they score you. So opening to verbal command being like, hey, can you open your eyes? And then them opening their eyes. That would be a 3 for the eye response. A 2 is opening your eyes to pain or to stimulus. And so unfortunately, this typically involves like a little pinch. This is how we assess if patients can open their eyes to pain. Either a pinch or like the end of a syringe on a toenail can sometimes help people open their eyes. It doesn't always work, and if there is no eye opening, you would get a score of a 1. So to review, there are 4 points total for eyes. Opening spontaneously is a 4, to verbal command is 3, to pain is 2, no response is 1. You cannot get a 0. The lowest you can get is a 1. Moving on to motor response, there's a couple of like nuances here that I think people get tripped up with, so we will talk about them. So for motor response, obeying commands gets you maximum points of 6. And so that would be like, can you give me a thumbs up? And then them showing you their thumb. Or can you touch your nose and then point at the ceiling? Like that would give you 6 points. Localizing to pain would be like if you pinched them or poked them, they would be able to like cross midline to kind of like push you away. That would be localizing to pain, sort of like being able to point to where it is hurting them and reacting to it in a way that would push you away. Withdrawing from pain gets you a score of 4. And so this is like not crossing midline with like, let's say I pinched your right arm. You're not crossing midline with your left arm to push me away, but I pinch your right arm and you're pulling your right arm away from me. So you're not able to like fight me, but you are able to withdraw. So that gives you a score of a 4. That is different from flexion in response to pain, which is a 3. And so you will hear the term triple flexion, which is where people, so like in the leg specifically, you will flex the ankle, flex the knee, and flex at the hip joint in response to pain. And if you think about this, if I pinch you on the top of your knee and you flex, you're actually bringing me closer to you. And so that's not like an appropriate response to pain because you're not pulling away from me necessarily. You like that's just like an innate response. So it doesn't help you to avoid pain, so it gets less points than purposefully withdrawing from pain, if that makes any sense. This is like difficult, and I really encourage you to talk to the people around you, especially the nurses are amazing at the GCS exam. So like observe them and ask them, especially if you see something that confuses you. They do this all day, every day, and they have great pointers. So check with your nurses, ask them to like explain if they have a little bit of extra time, like how they came up with the GCS exam, especially if what they're reporting is not the same as what you are thinking, because they probably have a good reason and you could get some good learning from that. Okay, so flexion from pain gets you a 3, and you don't need to memorize all this. There are many charts, but I just want to like go through the things that we're thinking about when we're doing a GCS exam. If at some point you have this memorized and you can pop a GCS exam off really quickly, that doesn't hurt, but you don't need to memorize this at this time. This is just giving you like a nice understanding of what goes into the exam. Okay, so 2 points is going to be extension in response to pain. And so we talked about flexion, but extension in response to pain, or like posturing. So flexion posturing versus extension posturing, we know that there's the red nucleus in the brainstem, and when the injury is above the red nucleus, you'll have flexion. When it's below, you'll have extension, and extension is sort of associated with a worse prognosis, and appropriately so is given a lower score in the GCS exam. So extension is given a 2, whereas flexion is given a 3, and we already said that the motor response is sort of what is cluing us in to the prognosis of the patient. At the end of that, we get a 1 for no motor response, and so the lowest score you can get on that is a 1. So to recap on motor, you can get 6 points total. Obeying commands gives you 6 points. Localizing to pain, being able to cross midline gives you 5. Withdrawing from pain gives you 4. Purposefully withdrawing. Flexion in response to pain, so maybe not appropriate response to pain, gives you 3. Extension in response to pain is 2, and we know that that's worse because we know that the red nucleus separates those points in the brainstem. And then no motor response is a 1. Moving on to verbal response. This is more about like orientation status. And so like we said, if you're intubated, you are unable to participate in the verbal response. And so the maximum score that you can get if you're intubated is, so So you can get 4 for your eyes, you can get 6 for motor, and you can get a 1 for verbal because you cannot respond. And so you can have an 11T, which is the best that you can do if you're intubated. So if you're not intubated, a 5, the maximum score of a 5 is for somebody who's oriented. So if they are able to tell you where they are, what month it is, why they're where they are, what their name is, those sorts of things, that would be a 5. If they're confused, that could be a 4. So again, if you're like sleeping when they come in, or you're half awake, or you maybe had a little bit too much to drink and you're in the ED, you could get a point off for being a little confused. Using inappropriate words is 3, and this isn't like naughty language. This is like saying things that don't quite make sense, like word salad, or trying to explain something, but it totally being the wrong words. That gives you a 3. Incomprehensible sounds like moaning or grunting, that's going to give you a 2, and then no verbal response is a 1. And so that sort of makes sense that as you go down the list, you start saying less things that make a whole lot of sense. So to recap, 5 is oriented, 4 is confused, 3 is using inappropriate words, 2 incomprehensible sounds, and 1 no verbal response. Okay, moving on to the second half and the very last part of the primary survey, which is exposure. This is a pretty brief section for exposure. This in the trauma bay typically includes removing all of the patient's clothing in order to fully evaluate injuries. There are many times that patients will have injuries that hurt them a lot, and they are unaware that they have more injuries than that because those injuries are what we like to call distracting. And so if you have like a gunshot wound on your thigh, you might not recognize that you also have a really big cut on your arm and a really big cut on your back because your leg hurts really, really bad. You want to uncover the patients. That's sort of the rationale behind it. But at the very same time, we want to make sure that we can provide as much privacy and maintain as much dignity for these patients as possible, because this is a very scary time. And so you should cover the patient up with a blanket at this time so you can maintain their dignity, but also you want to keep them warm. If you remember from the last episode, we talked about hypothermia being dangerous and being part of the lethal triad in trauma, which, as a reminder, includes being cold, coagulopathic, and acidotic. So keeping the patient's body warm by giving them a warm blanket, which you can uncover in sections as you are examining the patient in the secondary survey, is something that you can do that is both helpful from a healthcare perspective and avoiding being cold, but also can like help these patients have some sense of control in this really out of control time. There will be times probably where patients may be covered in dangerous or caustic materials, and most hospitals have a decontamination room and specific protocols for specific materials, whether it be an acid or base or what have you. So as to appropriately decontaminate the patient, we are not specifically going to go into how you would decon different types of materials, but just know that if there is suspicion that patients may be covered in dangerous things, they may be shuttled to a decontamination room where the appropriate action will take place, whatever that may be. But this is a good time to mention that we do not know what is on our patients, and so as to keep them and ourselves safe, you should always wear personal protective equipment when you are interacting with a trauma patient in the trauma bay. And this includes a gown, a face shield, a hat, gloves, mask, all of the normal things. This is to keep you safe. It's to keep them safe. You really don't know what's going to happen. You may need to do a procedure in there. You don't want to waste time by having to put PPE on, even if they aren't covered in dangerous things. So this is something that you should do before you walk in the room. And if you do take the ATLS certification exam, this is something that you will say in your scenario when they say, okay, your patient's coming, what do you want to do? You'll say, hey, I want to put on my PPE and gather my equipment and perform appropriate hand hygiene, and I want to warm the room and have my fluids warmed and ready. So that's part of like the whole spiel. You want to put your PPE on so that that exposure piece doesn't hurt you, because you never know where these people are coming from, and we want to keep everybody safe, especially people who are trying to help, don't want you to get hurt. So that is the end of the primary survey. So let's recap because this was a quicker episode. So talking about the primary survey, we know that it is A, B, C, D, E. A stands for airway. We want to make sure the airway is patent. B is for breathing. C is for circulation. D, disability. E, exposure. So let's run through a scenario where someone comes into the trauma bay. So the patient will be wheeled into the bay if they're coming in on a stretcher, and someone will say, "Hey, can you tell me your name? What's your name?" And if the patient responds, you'll say, "Cool, airway's clear." At the very same time, at least at our institution, the trauma junior is reaching across the bed to feel the patient's pulse. And so if they can feel radial pulse, we'll say radial pulse. If not, you'll say no radial pulse, or you'll move straight to femoral. So if you can't feel a femoral pulse, you'll say no femoral pulse. And then you will do something appropriate in that situation. But for this instance, let's say the patient said their name. We're like, okay, their airway's patent. It seems like they're breathing enough to say their name. Radial pulse present. Let's move them to the bed, and then let's repeat all of these things. And so we'll transfer them to the bed. We'll ask them what their name is again, ask them to say something. If they cannot say something, if they haven't said anything, probably at this point they will receive oxygen. If their saturations are not very good, they may be intubated at this time. People will listen to breath sounds. We will feel for a pulse again. And so at this time, we've gone through A, B, and C very, very quickly twice. Okay. So then the exposure piece is happening. The disability starts at the head of the bed with, typically at our institution, emergency medicine or anesthesia is at the head of the bed for intubation. And so they will check the pupils, they will see if the patient is moving spontaneously, and they will see if they have a vocal response. And so that is sort of where the GCS will come from. But all of this happens very, very quickly. The exposure is happening. People have their trauma shears and are taking the clothes off before the secondary survey occurs, which we will talk about in the next episode. But I hope that you found these 3 episodes very helpful, and we will talk about the secondary survey and then move on to some more sort of like concrete topics that you may find helpful for your shelf exam or may just find interesting from a clinical perspective. But it was so fun for me to tell you about this, and I hope that I will see you next week. Bye! That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.